Good morning and welcome to our monthly webcast. I am Samir Mehta, your moderator, and this is session number 157. We have an extraordinary teaching case for you today, a distal left main calcified. I do not have exactly the plans which are there in place, and I would rather have you participate in that decision, but the patient, I think, is going to require a left ventricular support. With this brief introduction, let me take you to the cardiac cath lab where Dr. Kinney and Dr. Sharma are there. Samin did not want to give them any further idea so that they can participate with you both into the decision making. Good morning to your staff. I think this first month for the new fellows.
Yep, first month for the new fellows, and the rest of our staff is the same. The usual common face, and welcome our CCC live audience. Myself, Dr. Keeney, my left side. Actually, we have our guest faculty, which we bring periodically, talking about the special subject and subject of this microvascular dysfunction, CFR, which is a lot of papers have come, so that will be part of discussion. Joe Sweeney is our designated microvascular dysfunction expert, and we'll hear from him during the presentation. More important, we have two fellows, Rajiv and Ali.
And Rajiv, who is a chief fellow.
Yep.
Wave, guys, so they can see you.
So good. Everybody can see well. So we are ready to start.
Wonderful, and Joe, nice seeing you.
Good to see you.
And the point, your point was very clear that what we are going to do for this distal left main bifurcation, nor I made the assess in our presentation, the e-blast, and even here. So let me just quickly show this case, and I think there may be a little outside the teaching which we usually do. Our disclosures are about the same. This is the case number 157, 78-year-old, multiple comorbid condition, as a liver cirrhosis, ethanol abuse, small cancer, AFib, thrombocytopenia, and the multiple episodes of GI bleed. That is one of the big issue. When he had a positive stress test a few months ago, they did the cath, and of course extensive disease was no antiplatelet therapy, was put on heart failure medications, guideline directed medical therapy. So whole question was, EF was 32%, severe left main and 3 vessel disease. The question came down that what to do in that time. So consulted, patient was done outside, and consulted Dr. Keeney, and basically said, let's do a trial of clopidogrel, at least to see whether thrombocytopenia patient can tolerate at least one antiplatelet therapy, because surgeons declined this particular case. And I'll tell you why exactly, because of the comorbid conditions. And this is the angiogram. Go back to the angiogram, please.
So, before Anu, 1 second, you do show us the angiogram and the plans. I mean, this is really as complex as it gets. When we call it complex coronary intervention, it is not only the technical complexity, but even the complexity with this patient, absolute entire textbook of medicine. Anu, please go ahead.
So EDP was 18. And you can see the left ventricular function here with just about 35 or so. And this is the right coronary artery.
Wow.
Probably more complex than the left main.
Yeah, that itself is a...
Very...
Anu,
was this in your previous angiogram? Has this worsened?
Yeah, we know.
Same.
Same. But when I saw him in the office, it was the same. This is not moving.
This could be the part of the live case maybe next month.
Yeah,
and this is the left main. Distal left main.
There you go.
If you see in this view, see that it's distal left main, not extending truly into circ or LAD.
So, Anu, straightforward, why not give it a little protection to the patient by doing the right first?
No, I think in this guy with the low, this is the reason for discussion with this case, in the sense for this patient, for survival, what you need is left main.
Absolutely.
Rather than the right coronary artery. We already have given him a challenge with Plavix. He was about just below 100, and now today it is already 62, 65, his platelet. So he's telling us, and we have seen this kind of cases. We are a big center of liver disease and management of liver problems, liver transplant. So we do get these cases, and we try to do one particular lesion and see how they do. So the biggest reason when you challenge them is bleeding. If there are esophageal varices, they get GI bleed, they develop gastric ulcer, duodenal ulcer, and that's the one that usually then makes us stop the antiplatelet agents. So I think do the left main, see how he does, and if he does okay without any bleeding, after we do the stent, maybe we consider right coronary artery or manage it on medications.
But I think that was a very important point, Samir, what you just said. When I saw the angiogram, I said the same thing, that the RCA looks very complex, but only problem is, in this particular case, you have to do one lesion, and that has to be the left main.
Completely
Yeah.
agree, and I don't think there is much of a doubt on the basis of prevalent literature to be using the Impella catheter here.
Yeah. So this is the case, although there is just this morning, some report came out, and I'll try to address that next month in our webcast. So this is the case now. Now, Anu, tell us the strategy and then go forward. So while I'll complete my presentation. Yeah.
So we do have the Impella in place because of the complex disease, and then what we will do
With the single
again,
access?
there will be a single access we already have, so we have a 7 French. But the way we will do is I'll wire it into the LADs.
Anu, angiographically for the left main, not much of calcification.
Yeah, let me complete.
Angiographically, but
yeah. So once we wire into the LAD, we'll do the IVUS and assess the left main lesion.
I see.
Angiographically, yes, there's no calcium. So I think this is a different one that we have taught multiple times, how to do two stent strategy. So we can also now show in this case how we can do a single stent strategy and a bailout if it is necessary. So the goal is we will just do, probably flex Wolverine to the LAD, and that's actually a diagonal lesion which we didn't see in the previous angiogram, but we can do that and then image again.
So question was very important. The earlier angiogram was done outside. There looked like a lot of calcium. It turns out to be, I think, more calcium now is in the right coronary and in the proximal circ than the left main truly. See, the proximal circ has a lot of calcium and actually less calcium in the LAD and distal left main on this. But as Anu pointed out, we are going to do an image will help us. And this is the kind of that mild, moderate type of calcium, which will decide based on the imaging, do you go more aggressive in terms of plaque modification using atherectomy, or you can just do the simply with the cutting balloon and so.
Prediction is there will be no calcium. We can just do. Now the question is same, high pressure balloon, or you want to use cutting balloon Wolverine. Cutting balloon Wolverine is still good for fibrotic lesions also. Don't have to be calcific, but even fibrotic. So the prediction will be it will be non-calcified fibrotic lesion. We'll do cutting balloon and stent across.
Okay. Let's
Anu,
go.
would you wire the circumflex or go straight just focus on the LAD and stent across and deal with
No, I would not wire the circ, will stent across. But we always we say it is on description of the operator, and I'm sure most people will say they want to wire the circ, but nothing wrong in doing that. Yeah.
But in the provisional stenting in your app, which will show side by side,
we'll
do you
show
wire routinely in the app in the left main? I'm talking about left main.
Routinely we do wire because that is what everybody will do.
Right. So therefore, coming back to the point, so non-left main, I think that's okay, but left main, majority of the people will wire the sidebar, may not do anything to the circ if you don't want to do, but will wire the circumflex. With that note, the guide is going to go in. All right, guys, let's put a guide in, and we are ready with the imaging. Make sure you continue to show hemodynamics below when we come back, and let me go the presentation now. Let me come back to it. So this basically was, you saw the 95% very complex lesion, and the diagonal was some disease there, high SYNTAX score, and patient did okay except slightly more thrombocytopenia. So this basically goal today is calcific left main bifurcation, but we learned just now less calcium in the left main, and this always happens, your equipment when it comes from outside. And then idea was that maybe use IVL if necessary, Impella support for sure. And then I put a question mark. You see that 1 versus 2 stents. Our teaching always had been your bifurcation distal left main, you do a 2 stent. But in this case, in view of GI bleed and thrombocytopenia, so I think 1 stent will be okay. So this is our assessment and predicting patient risk as per the latest guidelines. So heart team discussion happened, yes. CABG STS calculation, syntax calculation, which have been done. Syntax STS score is 6 plus, syntax is 36. This patient is not has a cirrhosis. So many other factors which are not part of the our syntax and STS calculation are also particularly frailty and malnutrition. This patient otherwise robust, not frail, but have a cirrhosis clearly. So therefore it's a non-surgical candidate. So coming back to the point, with those factors, although this patient may become rarely appropriate, by definition we call inappropriate, but new definitions is rarely appropriate. The appropriate, may be appropriate, rarely appropriate, but the key is in this case, after heart team discussion, to me it becomes class A, appropriate, because patient has seen the surgeon, and at this time patient has been declined with the surgery. So with that note, so question always comes down to the support. This patient has an EF for about 30 to 35%, so it's a good case for support of, because one most important is that you need to do revascularization. There's no back, no surgical bailout. We are it. So you need to be prepared fully in this particular case. Sometimes even with a normal EF, which we have shown rarely, the left main are very calcific, that we do an Impella or balloon pump. But in this particular case, appropriate, and this is actually ongoing trial, Protect 4, their cutoff actually is 40. Maybe I should change this number 20 to 40, because this number came from the Protect 2. So maybe we make it a 40 now. That anything more than 40, your normal EF, but 40 is part of the center category where Impella may be beneficial in these patients. So with that complexity point of view, no, at Sinai, we do about 4 to 5 balloon pump and 10 to 12 Impella for these high-risk PCIs. So with that note, they have, ready?
I just want to add one other thing.
Let's go back.
People will say, via the circ and image the circ also.
Anu, also 7 French guide, no?
Yes.
Yeah.
This is a 7 French guide in this particular case. Creatinine is okay. Yeah. So key was that if you have dissection, if you have to put a 2 stent, we would avoid it, but we can do. You want to go different view?
See, one other thing I have issue with this single access is, there's
guide. Yeah, guide movement is very limited.
That's
Single
the biggest
access.
problem when you're doing left main PCI. Okay, now I think I'm in the septal. Yeah.
Good. Okay. All right. So
Okay,
let's go to
give
the IVUS.
IVUS quickly. We can put, okay, hemo by the side. We can show the IVUS, not full screen, but okay, you can show full screen IVUS.
And Keski.
No, can you put the hemo? I want hemo
Samin
as
and
a
Anu, I
small
want to,
in the side.
since this is going to be used more and more often, how significant is this issue that with the single access, the guiding catheter support could be compromised? Have you noticed that as a result of it, you're using more guide extension catheters just because, I mean, in many ways, to me, it is looking like you have the benefit of a single access, but the support is like a transradial procedure.
Yeah, so question is very important. So I think if you're putting a 7 French catheter, the manipulation is a little difficult. If you have 6, you can manipulate. But it's just a manipulation. But I think single access has certainly has decreased our vascular complications.
Starting IVUS.
Absolutely. So mild 1.5 gradient calcification.
Yep.
Call the guy.
This is in the
More
LAD
there,
right now.
little more there, yeah.
Okay. Flora, where are we right now?
Calcium.
Distal
No, all
left
the
main
time.
still or?
Yeah. Still
Yes,
clocks already.
We have to
Now
see
the
where
branch
we
is
are.
coming from 3 o'clock. It's a distal left main. Not much calcium. Yeah, looks like just attenuation. Distal left main has not much calcium. I will stop.
Huh?
Yeah, the Dr. Kinney, as you said, distal left main has not much calcium. No calcium.
Okay, so there is no calcium.
That
Now,
was a
what about the
prediction.
circumflex? No, angiographically, I would have agreed. I mean, clearly. Remember when we did the trial called MACE, what we did
Flush
is
it.
that operators read the angiogram and classified them mild, moderate, or severe. I mean, none too mild, one group, moderate, and severe. And then Jeffrey Popma was the score lab. And we found that in the severe calcium, we have 97% concordance. Means the investigator read and there. So mild was about 86, moderate about 92% concordance. So we are very good in terms of reading, particularly moderate to severe calcium over 90+%. So this one on angiographically today's, I would have read it also mild calcium, and we see just very little flake of calcium only in this particular case. There is more calcium in the LAD, right?
Yeah, LED has like 1 quadrant to 2 quadrant calcium.
Yeah, see that LAD has some more calcium.
Ostial LAD, what's the cross-section area you have?
This is now I see the circ from 3 o'clock.
Yes.
Go to the distal. Yeah, this is the ostial LED.
So looks
Yeah,
okay.
looks not
Okay.
tight. The lesion is just a distal left main.
So you can, I mean, you could either do high pressure or Wolverine here.
But here,
I think
there is
there
some
is sufficient calcification there to do some ablation. I think
Mid.
Wolverine is a better choice.
Yeah. Yep. Now, what about the circ? We still have not decided the circ. Do we need to worry about the circ with the try to do on IVUS of the circumflex, or it will be too traumatic?
I think it'll be too traumatic.
Traumatic, yeah.
Yeah.
Okay.
Minimal benefit.
Yeah. It's called no touch technique. Don't touch it. Just go near it and come out before the circ realizes you were there.
Okay. You want to go back into this view to work?
Yeah, that's not a bad idea. Go back.
Okay.
So get us a 3-5 Wolverine. And then we will put a 4-0.
Yeah, the best side is more than 4 look. But yeah, a lot of flux.
Can you show hands also side by side and put the hemo in the corner?
Corner, and you want to show the app of the mini, the provisional stent, provisional group, provisional stenting. That's what the plan is in this particular case. So they are going to put our bifurcate app case also. So at this time we can take the IVUS away. Once we are ready, we come back. You want to put a wire in the circ or no?
I know there is a very relevant question which has been asked by, I hope I am pronouncing the name correct, Seema Naksane. If we plan to use a single antiplatelet agent, why not ticagrelor instead of clopidogrel?
Beautiful. Very good point. So I would say that no matter what study has been done, if you're talking about bleeding, more bleeding will be with the ticagrelor compared to clopidogrel. So in this case, I think we have advantage. We are given clopidogrel for 2 weeks, and we'll do a PRU. If the PRU is okay, every study has shown. I'm sorry, what?
No, I told him do it.
Yeah. So every study has shown ticagrelor will have a higher bleeding rate compared to clopidogrel, and that is why a lot of de-escalation after the acute episode is happening, and everywhere. No, you have to go back in here. Here. No, pull back. Little die. So I think we have little too. Yeah, this is the one. Don't give die. Yeah, good. So key is that every trial has shown that clopidogrel will have a lower bleeding, as long as, but at the same time, since we are talking about left main, we want to be sure that it's effective. This is a 12 atmosphere of the 4-0.
Okay.
This is the
no,
4-0?
This is 3-5.
3-5. Okay.
Wolverine.
It's a 3.5. Wolverine 8, 6, 8, 6 Wolverine.
Now
Yeah.
we got it.
Yeah, now we got it. 14 atmosphere
just-
multiple times. Yeah. Yeah.
Okay.
Fascinating our level of teaching here. You have simultaneous demonstration of a gorgeous 3D animation on the app, the ceiling camera picking up Anu's hand movements, and just amazing. Looks to have done a very good job there, the Wolverine.
Yeah.
Okay,
And in this case, although all the agent, all the newer stents have been fully approved,
4016.
both Zion, Synergy, Onyx, all for 1 month DAP. So I think this particular case, we'll try to go with the Synergy,
Yes.
4016.
How high were you with the Wolverine there?
12 atmosphere. And open nicely with the 3.5.
Yeah.
So now circ did have an intrinsic disease away from the ostium, 60-70%. So if anything need to be done, I would say everything goes. You're probably better off just
Take
leave the
another
circ.
picture.
Yeah, okay. Let me do the RCA. No.
Look, circ looks good. Go back to the original view again.
But question is, should you put a wire now?
Anu, a very interesting observation made by Bernard Wong. Are you using 7 French 45 centimeter femoral sheath with the short Impella sheath? Guide and Impella interaction is worst with the short femoral sheath and long Impella sheath.
No, long sheath.
We have long sheath for the guide.
Yeah.
Despite that, there is interaction. Yeah.
But you're absolutely correct. So even short sheath is even more troublesome. Every time we go through, we either 6 or 7, we use a long sheath.
So Bernard, the clarification for you. In
Yep.
the meantime, one of the most remarkable and extremely pleasing observation I have over the last at least 5 to 6 months is the significantly increased viewers from Pakistan.
Beautiful. Fantastic.
Okay, so this is 4016 now. Again, we're not coming up to the ostium, maybe a few millimeters inside. Okay, die. Yeah. Good. Okay. I'm going to take a scene.
Good, that's good. Okay, going up.
Okay, right. Good. Okay.
You have to pull back so the 8 millimeter and you do a pot is enough.
okay,
Yeah, it's
we
okay.
can-
Go up. And 4.58.
Yes.
Left main was 4.5 or 5.0? 4.5. So 4.58. Yep.
Okay, down.
Negative. And go to 12 atmosphere. So remember, you always have to have, once you're applying the pot, that you have enough room for the proximal. So as long as they're like 4 to 6 millimeter
Not
in the
in
main
this
vessel.
case, it's a short left main.
Yeah. And it's a short left main, that's why a lot of people will bring it up to the ostium. That's not our practice, but that's a lot of teaching, common teaching in Europe. They always bring the left main up to the ostium. Anytime putting a stent in the left main, bring it to the ostium.
So, circ no touch technique, pre-post looks the same.
Absolutely.
Okay,
Flow is fine and not significant plaque
Yep.
shifting either, I think.
Yep.
So
And
we have a PRU of 184, saying that he's a responder.
so anything less than 230 is okay. So coming back to the point, I think the issue, we are dilating the pot and then we are going to do the IVS again. But the key
We
is
can
that
keep playing the video of this is, single stent across. And like I mentioned there, we have wired the circ. That's what most people will do. And, you can go to bailout. You can now say that if there was plaque shift into the circ, what would I have done? So there is, at the end, I think if you give me a few minutes, I can go over the app to say exactly what are the steps of the provisional stenting. Because every time we only show mini crush because there's a provisional stent technique also. Go up.
going up. Okay, this is the 4.58,
See, my guide is out.
16.
Okay, down. We can IVUS now.
Yep.
Get the IVUS.
Back to the set position. All the way. Gentry.
Now what was in the room 6? What happened?
Flash and reset.
I know, is the bifurcate demonstration being run on auto or is somebody handling that?
No, it's autoplay.
Yeah, beautiful.
Keeps going round. Yeah.
Very good, very good.
Same thing is on the website, but in the app, you'll have to, go back and press the replay. Yeah.
Lovely graphics.
Good.
Okay, check the image. Yeah, it's outside of 10. Okay,
Yep.
I will start to work. It's a native LED.
It's a homegrown, you know that, right?
Coming back.
Yes, I do.
Yeah. And
outside,
Andrew did
Homegrown
everything.
with a
did
lot of
myself.
effort, yeah.
To
Yeah,
outside.
with a lot of effort from us.
Yeah,
Yeah.
looks like this is the distal edge of the stent. Yeah, looks good. Well about, well expanded, and no. Now going to the bifurcation, it's a left main. Looks expanded. Come to the aorta, a little bit stick to the aorta, but full cover the lesion and expanded.
It looks like the little bit outside the ostium.
Yeah.
Little bit.
Wow.
We can think, come out.
Very short left main.
Sure. Yeah.
Okay, let's analyze the IVUS or we are good.
We are good.
So you saw that angiogram. So take the wire out. We do one picture.
Yeah.
With the wire, without the wire, with a low mags. That's always teaching.
I just want to make sure I don't want to take the complete wire out.
Okay.
Guide is sitting there.
Sure.
You may lose the guide position. Yeah.
Anu, somebody has asked a question. I suspect he was joining a little late because we've answered it, but still I think for viewers it would be helpful. Provisional left main LED is adequate in this case or upfront two-stent strategy?
Yeah. So very clearly that routinely should be two-stent strategy. This patient who is a chance for bleeding, we may even need to interrupt the DAP. But if you come out with a single stent strategy is your winner. So other way around, usually two-stent strategy is the winner. In this case, you come out with a one, that's a great thing. It's a plus point. To me, I would say putting a two-stent in this case was a failure of the technique. Putting a one stent and come out with excellent result is the win of the technique.
No, all depends. Means or what the circ lesion is. You know, circ, if we are calling here 30-50, many people will say single stent is okay. If the side branch, which in the left main to circ is more than 50%, that is one you have to consider two-stent technique.
Or otherwise also in this case, if let's say circ was tight, I would have done the aggressive plaque modification. There's a lot of calcium there, maybe a small burr, 1.5 or 1, and so, or just a cutting balloon and then stent across. Means even if there was a disease in the ostial circ or proximal circ, a true 1-1-1 bifurcation, here looks like it was a 1-1-0 or just 1-0-0. Yeah.
Are you planning to do something to the diagonal or?
No.
No. Remember we said in the beginning that you have to refrain from going behind other lesions. One lesion that this patient needs is a left main. We don't know how he's going to. We already saw that just with 2 weeks of Plavix, his platelets have gone down. So with another 2 weeks or 4 weeks of platelets, Plavix, his platelet may go further down. So just left main for his survival and leave everything else for medical therapy.
Or I would say that if patient can tolerate the right coronary, because if let's say patient is ever considered for the liver transplant, they will not clear it with that such a significant right coronary lesion. And at the same time, I would say in this case, if patient continues to do okay, no bleeding, platelets remain around 65, 70, may bring back for the right coronary.
But right coronary is very complex. You will need at least 60 to 80 millimeter stent there.
Yeah, but just proximal. Yeah. I mean, particularly that very ulcerated proximal lesion, which is very challenging, which way it is going to go, as you can see here.
Anu, the downside is also there that, I mean, he would have a massive infarct if he was losing the RCA.
I don't even know if he's ever considered for a liver transplant.
No?
Yeah.
I see. Yeah. So I think this is, the challenge. Clearly we decided that if one going to make him survival point of view will be the left main, and even if the RCA subsequently progresses, maybe we are hoping that this left main gives some collateral, will save him. Although right now there are no collaterals to the right coronary. Yeah, absolutely no collaterals. Okay. But anyway.
I think we will give a follow-up. I mean, he's going to follow up with me here. And then we will let you know if he did anything to the right.
Yeah.
Or like Will mentioned, maybe the right will be another webcast.
I think the right should be done because patient is still reasonable age and a lot ahead of it in terms of options. Okay. With that note, the excellent case so far, we can go. Our presentation continue.
Can we just finish that Bifurcate app?
Okay. Okay, you want to play
Show
the
that app so that we can finish provisional stenting.
Yeah.
I can, Anu, just give you and Sameen a feedback from the numerous questions that almost all of them are relating to the right coronary artery.
I'm sure everybody wants us to do that, correct?
No, there are few people who have made the observation that, look, it's a critical lesion, it looks ulcerated and a lesion in a very large right, but I think you've addressed it exactly right. looking at the patient as a whole, considering the numerous challenges with this thrombocytopenia. I think your decision is a wise one, and we should stay course. And of course, as Anu mentioned, we'll provide a follow-up later.
Yeah, beautiful. Okay. All right. So this is our...
No. Please just play the app. No, that is the provisional stenting. The one that you were showing earlier, just that one. So here we said, see, wire both LED and circumflex, and we are saying non-calcific, so 1-to-1 NC balloon. We used, and we also said consider atherectomy if it's a. Now then we decide, see if there is a plaque shift. So if there is plaque shift, then you treat the circumflex before you stent the left main. If there is no plaque shift, leave the wire, stent across. Then again you assess the plaque. If it's less than 50, like here, we say that you can do pot, and then the case is completed. Exactly the steps that we did here on this case. But if there is a, if you have to, there is plaque shift, then you do a, KBI after pot. Reassess the side branch. If we think it is looks good, we are completed, and we always say for left main, you have to do imaging for checking the proper stent optimization. Yep. We're just showing one more, that if there was a plaque shift, that you did NC balloon, there's a plaque shift into the circ. Yeah, bailout, yeah. So, wiring both, predilate the main vessel, consider atherectomy 1-to-1 of the left main. Now you see there, plaque shift is, you're saying less than 50, so we stented.
More than 50 plaque.
Yeah, no, bailout after we stent.
I see, okay.
Yeah, now, we finish this. So you have plaque shift after we stented. You see that? So what you have to do, take the wire out and recross. Very important. Then you predilate the side branch. I guess we need to perform KBI.
Yeah, right there.
So what we did was just predilated the side branch. And if after we predilate the side branch, if there's more than 50, this is the time you will place a stent in the side branch. Now this is where again there's a lot of discussion happening. So you already did place a stent, you did a kissing balloon, and the discussion always is there that perform pot. We already performed pot once, so we will not advise perform pot again, but there is this another group of people who would want to do pot, then we do KBI, then go back to pot. I think we have shown in multiple of our live cases with imaging, there's no need to do that.
Yeah, so I think the pot, a KBI or one pot, I think that's good enough.
Yeah.
But KBI is the key here. KBI is the key. Okay?
Yes.
Beautiful demonstration. Fantastic. So let's go back to our presentation now. We go to our the latest issues of for the month, and meanwhile you guys start taking the guide out. Guide is already done.
Guide's out.
And then we start closing the Impella. So majority of cases we take out the Impella in the cath lab. Very rarely we'll leave it. Some cases we have changed it to a balloon pump if we need it, but very rarely for patient with the high risk PCI, that I would say of the 100 cases, maybe 1 or 2 maximum will go to the CCU with the Impella in place. For the cardiogenic shock, we still leave some cases, but not for the high risk PCI. So what is the topic is a little unusual today. One is the differential impact of the CFR and FFR. A lot of paper have come in terms of assessment of them by the defined flow, the Elias registry, and question is what additional test are needed, or CFR adds to it, and more important, IMR. Then the focus review of the month is the mitral infarction in young age with this cause, angiographic characteristics, and management. So now the first one is the FFR, the CFR. Now, remember FFR is the gold standard. FAME trial showed if your FFR is less than 0.8, you do medical therapy, you had trouble. And this is a 5-year data. Medical therapy group, more than half require revascularization. Other people may say that, remember, other half didn't require revascularization. And even the event rate was 14 versus 37%. So even in the FFR, patients who are FFR negative, or FFR means low FFR, and got the PCI, still had an event rate about 14%. The question is why? Is there anything else we can do beyond just diagnosing by the FFR to add our predictive value of the subsequent outcome? So this is our gold standard. And this is where means the event rate continues to happen. Same thing like patient with a stent. You do a initial restenosis at 1 year, but after that 1 or 2% continues to have a trouble. So this is the same feature has come back to what if there are additional physiological testing? Anatomically there are angiogram, or what do IVUS and OCT? That field is totally different, and we have discussed that. But what about in the additional coronary circulation with the functional imaging? One, we know the FFR, IFR is on the left side, the gradient in the epicardial vessel, and your microcirculation, and which is called indices of myocardial microcirculatory resistance, index of microvascular resistance, IMR, and combining both FFR and IMR is CFR. So question is, in the past, CFR was a very tough test to do. It required a lot of, one, in the cath lab, using a Doppler velocity, and then of course you do it by the various MRI testings and so CFR, when I did my fellowship back in early 90s, we used to talk about CFR because that was the test available at that time, and it used to be with a Doppler flow, very difficult, and the value was less than 2 or more than 2. So basically that is our combination of the coronary flow reserve, the fractional flow reserve, and index of microvascular resistance. And of course PD is your IFR or RFR as shown there. So this is where you put it together. So CFR, flow at rest versus hyperemia, which are both for micro as well as macro vessels, IMR for microvasculature, microvessels, and FFR, IFR, RFR, PDPA, all for epicardial vessel. And these are the various tests which we have for some require giving adenosine, and of course some require giving even acetylcholine and so. So this, the CFR has been studied in various studies. As you can see there, an idea there is that anytime you have CFR less than 2 has a bad outcome. The whole question comes, yes, you've done us, but what about interacting both CFR and FFR? And we have the data on that now in recent time. So, but most important is how do you measure the CFR? So there is classically the Doppler derived CFR on the left side, and now we have a more user friendly, and that is the thermodilution CFR measurement, which is a little different. Doppler values are a little lower compared to thermodilution by 1 point. And I'll ask Joe on comment on that, but there are two techniques which have been historical, and this is actually very nicely in this paper. On the top in the center is the Doppler derived CFR, and in the bottom is the thermodilution derived CFR. And therefore, the question is thermodilution of the CFR overestimate by about 1. So threshold is maybe 2.5 with the thermodilution, and with the Doppler derived was 2.0. So with that note, let's ask Joe, who has been very much involved in calculation of CFR and IMR, that how easy it is, and just comment on which technique is better, or is still in evolution, Doppler versus thermodilution.
Yeah, thank you. Thank you, Dr. Sharma and Dr. Kinney, for bringing this really exploding topic to the forefront in this live relay. So coronary blood flow, as many of you know, is an assessment of, or coronary flow reserve is assessment of the coronary blood flow and its ability of the vasculature to accommodate increased oxygen demand. And we have a way to test it in the past, as Dr. Sharma said, which is the coronary flow reserve, which is basically just a ratio of the flow at rest to the flow at hyperemia. And generally, historically, that cutoff, the cut point, is anything greater than 2.5 is considered quote-unquote normal, meaning that coronary vasculature is able to accommodate the increased blood flow. That old way of assessing coronary flow reserve was by looking at flow velocity, and that was done by a Doppler wire. And that wire was fraught with intra-case inaccuracies. It was very dependent on the patient's heart rate, the blood pressure. Many variables changed the CFR done by Doppler on the same patient from minute to minute. So a lot of it fell by the wayside. But this newer technology, which is the coronary flow reserve by thermodilutional method, is what I think is a little bit more accurate and a little bit more user-friendly. And this is, in the cath lab here, what we do is we put a coronary flow wire down, and this is the platform here, the CoraFlow or the CoraVentus.
Bring the machine.
And through this wire, we're able to assess a lot of different indices, but focusing on the coronary blood flow, what we do is we assess coronary blood flow by looking at flow. And we look at transit time. So it's just like a cardiac output with a Swan-Ganz catheter. You have a proximal and a distal thermistor, which is a temperature and pressure sensor. And you basically inject saline to the quantity of 3 cc's from the guide down to the vessel in a prefixed length where the wire is, and you time it. And it gives you a transit time. And we do generally 3 of those here, and we take an average. And that gives us our resting coronary blood flow. And then we induce hyperemia with IV adenosine at a general standard dose. And once we've achieved hyperemia, we repeat the coronary flow. And then we get an average transit time of those 3. And then it's a simple ratio. It's a very simple calculation. And what this paper, a recent paper came out that looked at comparing coronary blood flow or coronary flow reserve using Doppler indices versus coronary blood flow using thermodilutional indices. And the correlation is modest, weak to modest at best, to be honest with you. I think an R factor of, or an R coefficient of 0.3. So we have to accommodate that, but what it did show is our cut point should be a little bit different, and the cut point for a CFR by thermodilutional should be 2. That increases the sensitivity of detecting a reduction in coronary blood flow. So that is the aspect of CFR as it pertains to this topic, and if you want to show that last screen, we can show the nice thing about this CoraFlow wire is it allows us to check resting indices such as a resting full cycle ratio or RFR. We're able to check CFR like I just mentioned, and then we can calculate the index of microvascular resistance. And that's a simple calculation looking at the transit time with hyperemia multiplied by the distal pressure. And then we are able to get an FFR.
And does the machine, if they can focus that?
Yep. In the cath lab here, we actually have every room wired with the CoraVentus platform, and we have a portable machine right here if you want to show it. It's actually quite nice and portable and easy to work with. There was a little bit of a learning curve that the staff goes through, but once it's up and running, it's very simple and takes about, on average, about 6 to 8 minutes per case. Get these indices. The question is, what do you do with that information? And I think that's where Dr. Sharma is going to go into next with some papers that have really talked about this discordant group. This group where we have CFR that contradicts an FFR and vice versa. Because we know what to do with the patients that have a low FFR and a low CFR. Well, those are high-risk patients and should get revascularized. And we know what to do with patients that have a high FFR and a high CFR. But what do you do with the patients that have the mix and match?
And at the same thing, that these are the values which we have spoken, and the IMR value is more than 25. So less than 25 is good, and more than 25 is bad. So these are our cutoff point for. So key is that how science has gone. That became so simple, which used to be a lab experiment and scientific project could be a clinical project to do it. So the question was, there was one study about comparing with the CFR and the microcirculatory resistance in patient, and you can see there. So it's never a one-to-one correlation. CFR, there will be a group of patients where there will be a low CFR, but your microcirculatory resistance is less than 20. So that's a good group, low, but could be high. So there is always, you'll see a discordant in various areas. And what has shown basically is that this is very interesting, that if you are low CFR and you're high IMR, less than 2 and IMR more than 25 has the worst prognosis.
Very high
28%, as you can see there. So key is that yes, it does add CFR and IMR to the overall outcome of this patient. This is one of the old one which we have presented here. I just brought it for discussion. And the second point was also with a non-obstructive CAD, this IMR in presence of spasm or no spasm has really shown that anytime you start getting higher IMR, in a patient with a normal coronary, non-obstructive CAD is associated with adverse major cardiovascular event, and more importantly, they have higher angina category.
And that's the key, Dr. Sharma, is that the patients that we're doing this on are patients with INOCA or MINOCA. So these are non-obstructive coronary disease. Right now, the data suggests that when you have an FFR that's less than 0.8, checking IMR or CFR really hasn't added much. There's some recent literature which we'll go through which may help us predict further risk, but by and large, when the FFR is less than 0.8, these indices don't really come into the play.
Yep. So IMR basically, so I think, and I'll sum it up in the sense that when we use all these testing. So one of the study was the pressure and flow. So you do combination of FFR and CFR. So this is the group of patients. So with the group that you do both CFR and FFR, and now advantage is one wire can do both.
Correct.
And that is the biggest thing. You're not putting a multiple wires. And so basically the defined flow study was that if your FFR of more than 0.8, does doing a CFR adds any value? That was one question. Second, if your FFR less than 0.8, but your CFR is less than 2, you do PCI, you don't, that may be your control group. But what if your FFR is less than 0.8, but your CFR is more than 2? So the proponent of CFR group said, this group in the center, below, FFR less than 0.8 and CFR more than 2 will do very good. Just like as if you have revascularized these patients. And this is what the basically the defined flow study, individual diagram of the, and you can see here that clearly the one category was that you have a high FFR and high CFR. That's grade 1. Second group was you have a low FFR and low CFR. So 1 is the best, 2 is the worst. Now you go to the number 3, you're the high, FFR is high, but your CFR is low. Second one, that your CFR is high, but your FFR is low. So 4 categories. So basically it turns out to be, this is where the discordant, which Joswini just spoke about, the 37% of the lesion are discordant with a CFR and FFR.
And just to note, Dr. Sharma, if you go back one slide, this scatter plot looks almost identical to the scatter plot from the study 4 years ago.
Yeah.
In the sense that when you compare FFR and IMR, that discordant group is about 40%. And it's the same when you look at FFR and CFR.
Absolutely. Absolutely. Same 35 to 40%. So just concentrate on the right side. And look at that one. Your FFR is less than 0.8, but your CFR was more than 2. Guess what? Your TVF and primary endpoint, very high, 10 to 15%. So therefore, what it tells you, the CFR did not matter.
No,
it was the FFR was the trouble. If your FFR is low, and then of course other groups are shown in the center, and there you can see increasing your low FFR, high CFR, still event rate was very high. So key is, there's a very confusing, when they presented also, very confusing conclusion, but I would say very simple, read that way. The death MI and revascularization 2-year was inferior in patient with FFR less than 0.8, but CFR more than 2. So therefore you can say, if your FFR is less than 0.8, probably you don't need to do CFR.
Correct.
And this is what we learned from the defined flow. Then there is a Ilias registry, multi-center in Europe, Korea, and China, other places, and they have also looked into this aspect of FFR, IFR in intermediate group and so. So what they did is, what about we know that less than 0.8 is trouble, or maybe original data, remember, of used to be 0.75 for FFR. So what if in 0.75 to 0.8, by adding CFR, does it give? We know that if you're truly in real low FFR, it does not matter. But what about this intermediate group? Whether CFR will add to this intermediate group. So these are the characteristics of the patient, and more important is that which is in the lower, which I have put in the graph form, that your deferred PCI in these group, or you did a PCI, didn't matter, but it did matter that in this intermediate FFR group, if your CFR was more than 2 or less than 2, you see that if you're less than 2, you are in trouble. So therefore, in the intermediate group, is sum it up here, that depressed CFR, which is on the right side, you do a PCI, you had a lower event rate compared to your deferred. But if your CFR was more than 2 in intermediate group, PSI did not make any difference.
So two totally different messages. Yeah. Two trials that are one the defined flow, which is a prospective study, about 400 patients in a very, very well-defined protocol. The operators had to follow a specific predetermined protocol. In the Elias, this was a registry, and this was about 2,000 patients, more patients, but the operator was able to do whatever he wanted to do. He felt like the patient needed to be revascularized, they did. So when you look at the actual raw data of the TVR or the TVF, it's identical.
Yep.
They had the identical same outcomes. How did they come up with different recommendations? And by and large, the controversy is that what they were comparing to. In Elias, they were comparing TVF compared to revascularized patients, so patients that got PCI. In defined flow, they were comparing outcomes TVF to their normal population.
Yep.
So it was a different population they were looking at, yet they got the same results.
But still, I mean, I would say that the key was CFR did help a little bit, only in a small percent of cases in this intermediate risk group. So this basically was that the low CFR did help. Then second, from the same data was, what about you combine FFR and CFR? Same feature, the same way. Your discordant 19.2 and 14.4, same, 33-34%. Other are concordant, and you see individual outcomes is very simple. FFR normal, CFR normal, best outcome. FFR abnormal, CFR abnormal, very high outcome. In the middle, if you see, if your FFR is abnormal, whether CFR normal, abnormal, doesn't matter.
No.
So therefore, it turns out to be that FFR abnormal again trumps over CFR. So this is basically the plot for there, and they basically showed that it's the FFR, which is very important, and so.
If you go back one slide,
yeah.
If you look at the curves in the middle, there's 3 curves. There's the orange, the blue, and then the dark green. And that is the 2 discordant arms and those that are revascularized. And you see that there's no difference in those discordant arms with those patients that got revascularized. So in essence, they said the CFR didn't add any risk predictive value above and beyond what FFR provided.
And that actually the editorial was also that should we be, by Morton Kern, that should we be routinely using CFR, and his basically was not necessary. So they basically put it together very nicely, this functional coronary angiography structural on the left side, macrovasculature, microvasculature, the functional coronary angiography on the right side, what we have for the epicardial vessel and for the myocardial. There was a paper, this was editorial, but I changed quite a bit. We made it, so it's a modified editorial comment. And more important is, let's sum it up. What we said in this 6-7 papers which have been published. Very simple. FFR, IFR positive, not much more needed. You don't need any further risk stratification, because you may do anything but will not help you further. If your FFR, IFR negative, CFR may further risk stratify in those cases, if you need to worry about because of risk factors and so. And your FFR, IFR negative, but IMR positive may explain the chest pain. The question comes that there is a limited therapy for these patients for the microvascular dysfunction, which many of these patients are already on. So, Joe, I want this crisp, your assessment and your recommendation. Patients who are negative FFR, but they have now the IMR positive or 28 or 30.
Right.
What do we tell them?
So if they have a high microvascular resistance and they're coming in with chest pain, I tell them two things. Number one, I'm able to give them a diagnosis.
Yep.
And that is a significant burden or relief of burden to them. Why do I keep having chest pain? Why do I keep going to the emergency room? Well,
Which actually was very interesting. Just a case last week. I did a stent about 2 years ago. The stent was fine, but patient has typical angina and came in.
Yeah.
And we did this FFR, and FFR was negative, but IMR was positive.
Positive,
so at least
correct.
we have the region for the chest pain. Yeah.
And that is a big relief for the patient. The second thing is the therapies are still undergoing, investigation, but by and large, beta blockers, statins, antiplatelets are the go-to. This is an evolving field as we speak. A lot of changes, a lot of robust data. It's an alphabet soup. It's very confusing, to say the least, but it really speaks to the fact that we have to identify and come up with more concrete protocols, and that's what a lot of us are doing through various societies, one of them being the Microvascular Network, which is a group of doctors that have in microvascular dysfunction, where it is our charge to come up with guidelines and protocols that other doctors and other centers can follow.
Beautiful. Now, Anu, you want to make a comment on this?
Before a couple of...
FFR, IFR, negative IMR, right?
Yeah.
What is the CFR there?
Say it again.
What is the CFR for your last group? FFR, IFR, negative?
Yeah, the CFR may, if you're CFR positive, you have a little outcome, but it's like in between. You remember second category. FFR, IFR negative, but CFR may further risk stratify.
CFR doesn't matter regarding to revascularization.
Yes, yeah.
No, I'm not talking that. I'm talking the last group.
Yeah.
FFR, IFR negative, right?
Yeah.
What is the CFR? Negative, positive?
It can be both.
Both.
Then you're saying IMR. That you have to, because you still have microvascular disease, right? Here IMR you're talking is probably spasm, endothelial dysfunction, all this.
You have high microvascular resistance as measured by the IMR.
You understand what I'm saying?
Yeah. No, exactly.
IMR positive, you again classify that. Is CFR positive, CFR negative?
Yeah.
Right. That's the discordant group. That's what we're talking about. The discordant group that we still don't know what to do about.
Probably again classify that. Say
And it's about 40%.
Endothelial dysfunction, statin.
Could be.
Other one considered maybe antiplatelet, because you have normal coronaries and now you're telling the patient take the 4-6 different medication. They do have side effects for that.
Yeah, and particularly antiplatelet therapy in the InfoCast group and spasm have been negative actually.
Yes.
Yeah.
Having a more complication, more bleeding and negative outcomes. So they're saying if you're spasm, you definitely, if you're shown macrovascular spasm, antiplatelet therapy is not answer.
And that's why part of this protocol of assessing microvasculature also has to assess for vasospastic angina.
Yeah.
So you have to have both protocols. You have to have an adenosine and an acetylcholine arm, which is really what the tried and true setters are doing.
Okay. Now, Samir, you have some question? Yeah.
Yes, I have actually, there is a question from audience, and before that I wanted to recognize Joe Sweeney, a remarkable member of your faculty here, and I wanted to congratulate him for his cutting edge work on coronary physiology. Joe, there is a question specifically for you. Are you using CorFlow for ACS spasm studies? You've kind of alluded to it just now. If so, what is your process?
So for the ACS studies, we're not using it a lot with ACS right now, with Minoka. Mostly our patient population has been INOCA. But there's definitely literature to support its use in Minoka. I think as we get our cath lab up to speed where we want to be, we will start doing Minoka.
Wonderful, Joseph.
And acetylcholine and spasm, now we got finally approval. It's very tough to get acetylcholine in your formulary.
Yeah, in the old days it was ergonovine.
Yeah.
Which has, is fraught with a lot of problems. Nowadays, most centers are using acetylcholine. It comes in a very interesting preparation. It's an ophthalmic drop called Myocol, which we were able to get approved on our pharmacy formulary. And actually, we have 2 cases scheduled in August to proceed with this.
But it's available now, so they require a little extra effort. But if you're dedicated center, it will be required, because that is what those has been a dosage 18, either infusion or intracoronary 100, 200 microgram. There have been a few paper about safety of acetylcholine, and it looks like the low dose is fine.
Yeah, very low. You do a very gradual dosing. It's about 5 different doses, starting at 2 micrograms up to 200. Yeah. Obviously, with your vasodilators, nitro very readily available, as well as pacing pads.
So very safe. All right. So let's complete very quickly the second, our focus review of the month. That is MI in the young age, and the causes, basically the angiographic characteristics management. Very nice. Age less than. Question is, what is premature? 55? 50? So I think a lot of people say age 45 is probably right. Sometimes 45 for male and 55 for female. But key is the young age. MI young age, very nice paper. And they actually have shown that different anatomy lesion characteristics, usually single disease, very rarely left main. It's usually LAD, a lot of spontaneous coronary dissection, Minoka, as we have spoken about. Can happen. A lot of papers about it, very nicely put together. And then characteristics, whether it's a plaque rupture, erosion, or calcific nodule. Remember, the plaque rupture, of course, the most common, and erosion. Erosion is quite common in this group of patients, about 20% and so. But calcific nodule is uncommon, very, very rare. Less than 1% and so. And they have nice case examples of these patients with the non-obstructive CAD that's showing the calcific nodule, although very rare case, but did show. And then the overall combining MRI. So many times with the Minoka, you have normal coronaries, but you have infarction on the MRI. So therefore, you can always find some defect on the CTA or demonstrate non-obstructive CAD, but plaque. Which may have caused embolism. So many times, small inherent plaque rupture, embolism, but artery looks completely normal. And so, spontaneous coronary dissection, we are very well aware of, big factor, particularly postpartum. And so, and the lipid abnormality is very common, but it's usually the high, the LP little a and LDL levels and low HDL level, and so. Therefore, and also there are gender issues in basically women and men MI. So, plaque. Culprit erosions are more common in women, non-culprit, fewer, shorter, more stable. Then angiographic findings, non-obstructive CAD more common, high prevalence of sudden cardiac, the spontaneous coronary artery dissection, and so. And then, like, very important is the management. What is the difference is less likely to receive evidence-based medication. This actually has been on the forefront. I presented last month also about the gender issues, gender differences in treatment, and that basically less likely to go angiography. Now it is, I always say, is it the system fault or is it the personal fault? This always has to be probably education. And more are being treated conservatively. So there is definitely a difference of treatment after even diagnosis, one of the mechanism of the young MI in women versus men, but more importantly, management point of view, they get more medical treatment rather than going for coronary angiography. So this is a very nice algorithm they have created that how to manage these patients or how to work up these patients algorithm for patient with the. And this is a nice central figure. I put it together that obstructive CAD is still 80-90%. Minoka and spontaneous coronary dissection occurs in 10, 20 to 5% of cases. And one of the biggest risk factors came up here is smoking. Young age. We know that overall, once you get to 60 plus, chances of smoking are less than 10% with the CAD. We actually have our data is like 5-6% in our database. But smoking in a young age is very important, very high risk factor. And secondly, very high risk factor for subsequent recurrence. And this is very important. So smoking cessation is fundamental in management of these patients. And many of these cases, when they just have a plaque erosion, you may not need to do PCI. Because if you show a plaque erosion and lumen is good, maybe just put a DAPT, statins, ACE inhibitor, beta blocker. We talk about statins, antithrombotic therapy. Once you have spasm, there the question comes out to be. Once you have embolism, maybe warfarin or other NOACs. But usually, many of these patients are treated medically, particularly if there is no obstructive coronary artery disease, Minoka and so. So this basically is the field. So just sum it up now, we get to our time. The FFR low, high CFR and PCI outcome, nothing. It's the FFR which is important. Intermediate FFR and high CFR and PCI outcome, yes. In intermediate FFRs, high CFR did have a predictive value And the third point was the utility of combined FFR and CFR, impact of FFR. Once you're doing both, you basically FFR trumps subsequent management and prognosis. Premature MI is slowly rising and has different angiographic and characteristics. It's usually good prognosis and risk factor modification, particularly smoking cessation on the top. Very quickly, 3 questions. Following the true statement about the results of the defined flow study, impact of FFR and CFR, high FFR and high CFR at lowest MACE, or the combination of so. So basically is the true statement is low FFR and high CFR at higher MACE rates. So that is the key. FFR is the important one. Second, from the Elias registry of FFR, CFR, normal FFR or normal CFR has the best outcome. So basically is the low FFR and low CFR has intermediate outcomes. So that's the true. Everything else is false. That's true. Then lastly, the statement is mechanism of premature MI, plaque erosion need to be best treated by stenting. Plaque rupture is a common event. Spontaneous coronary dissection is common. Females calcific nodule occurs in 50% of cases, and plaque erosion is common. Clearly, the calcific nodule is very uncommon, less than 1% of cases. With that note, we end our today's presentation.
Samin, excellent review of some very difficult challenges of a massive amount of emerging information with coronary physiology. Joseph, thank you so much. As both of you were reviewing this, a thought, Anu, came to me about this case today. And I want to really compliment you on your very unambiguous strategy for the case. Today's case, I think, more than many which we have shown here, highlights how you can get confused and go chasing multiple lesions and forget the complexity of the patient. I think in this particular case, your paramount focus on what is the issues involved, the critical issue regarding the patient's thrombocytopenia, and how you have a strategy completely focused on that. I mean, people here could get lost chasing the diagonal, chasing the RCA, and end up having a great result, but a poor outcome for the patient. So wonderful. It took me really a while to, as Samin and Joseph were presenting, to think about, and I sincerely hope that is the take-home message for the audience. Once again, congratulate you. Welcome to all the new fellows, and we will conclude here and see you during the next transmission on August 16th.